Thank you very much, Chow. And it's a great honor for me to be with your team. I was there last year as well. Also, I was in your center for a couple of months, like 7, 8 years ago. Very nice program you have it. So my talk is about the role of TE in aortic valve repair and the ROS procedure. There's no disclosure. So the objective of this talk is to understand the pathology and mechanism of regurgitation in an aortic valve and assess the suitability for aortic valve repair or ROS procedure. To review the role of TE, especially more advanced 3D TE software in scientific assessment of pathology of the aortic valve and anatomy of the pulmonic root, helping the surgical team for appropriate decision making, and to assess the role of intraoperative post-op TE in detecting possible complications, residual aortic or autograft regurgitation, and durability for the aortic valve repair. So this is the survey, European survey. We don't have American survey about the incidence of valvular heart disease, but this is a European survey, and they did it in 5,000 people that they had a murmur, and they did an echo, and they found the most common valvular heart disease, the AS, 43%, and then AI, 13%, MR, and MS. So today we are talking about the aortic valve, so AS and AR, both of them. This is the anatomy of the aortic valve, normal anatomy. Most of the time is tri-leaflet. Also, 2% of general population can be bicuspid. So we have a 3-leaflet. They are unequal size. That's very important. They are not equal size. And they're coapting. At the coaptation point, they have a 3 nodule. It's called nodule of Arantius. And they coapt like a 4 to 5 millimeter coap together. So it means we have like a 4 to 5 millimeter coaptation line, extra line overlapping each other. And this is the valve during the systole. And surprising, this valve was described by Leonardo da Vinci in 1513. And he drew this nice picture of sinus of Valsalva and vortex of the sinus of Valsalva. And now we have a technology of 3D to show that aortic valve, as we are seeing in the anatomic specimen. Non-coronary clasp is below always because the surgeon is standing here. So this is surgical view from aortic side, non-clasp, right clasp, left clasp. Also, this type of picture is not possible in every patient. Maybe 50% of the time we can get it. So for aortic valve repair, these two giants are the pioneers of the aortic valve repair and valve sparing operation, Yakub from UK and Dr. Tyrone David from our center, that is still working very well. So Yakub described it in 1987, repair the valve and preserve the valve in a technique that is called Yakub remodeling. That's the way that you see it. And Dr. David did the operation as an aortic valve reimplantation. It means you put the aortic valve inside the dacron. At first, Dr. David introduced this technique of David operation, now we call it, in a normal aortic valve. But later he expanded to repair the valve and preserve it as we have it today. There are many modifications, David 1, 2, 3, 4, 5. And I had a really great pleasure to be with him in that year. I started my fellowship in ECHO in 1992. So I am in this with this valve repair and valve sparing the entire process. This is the schematic diagram of the aortic root. As you see it, the aortic root consists of aortic annulus. We don't have really annulus that we can measure. The one that we measure in the echo is called virtual annulus. That's in the red one. And we have STJ. Usually STJ in a young people is a little bit smaller than annulus. And then we have 3 leaflet. I'm showing you here for only 2. And this leaflet has something is called geometric height. This is the actual length of the leaflet, And we have a coaptation height. The coaptation height is the part of the valve leaflets that they coapt together. Coaptation height or coaptation length is about 4 to 5 millimeter, but geometric height of each leaflet is above 2 centimeter. most of the time like a 2.5 centimeter. So the aortic valve repair and aortic valve preserving was an art. So it is still art. And this art was developed by Dr. Sir Mehdi Yaqub in UK and Dr. David in North America. But now we have to make it as a science. We have to measure it. So what we should measure? We should measure everything that I showed you in the previous slide as surgeon can do it. So I believe that all the measurement that the surgeon needs to do it before start to repair the valve, the echocardiographer should be able to do it. And now we have the software to do it. The engineering part of the aortic valve repair and the instrument was developed by these two gentlemen, Dr. Schaefers and El-Khouri. El-Khouri from Belgium and Schaefers from Germany. And Schaefer developed this instrument to measure the geometric to effective height, and we call it Schaefer caliber. And we have a roller to measure the geometric height. This is the metal one. And we have it usually in every OR that we are doing aortic valve repair. We should have these instruments. And El-Khouri is the one that measured the free margin lengths of each leaflet. And El-Khouri is the same person that developed the El-Khouri classification for aortic valve repair. This is one of the last paper by this group, by Schaefer and El-Khouri, that how is the outcome of the aortic valve repair. And they showed that if the valve has a retraction or calcification or frustration, maybe it's difficult to repair, but still in 90% of time in tri-leaflet aortic valve and 70% of time of bicuspid aortic valve, the valves are repairable and they have a good durability. So these three are the risk factor. All of these three can be measured and can be identified by echo before even surgeon started. Retraction, we measure the geometric height. If it's less than 1.8 or 1.6 centimeter, we call this leaflet is retracted. Calcification is easy to see. Fenestration, if it's large, it's easy to see. If it's small, maybe it's difficult to see. But anyway, we don't care about the small fenestration. The large fenestration is the problem. And this is the report of aortic valve repair and valve sparing from Dr. David. We have now follow-up of 27 years or more than this. So I'm showing you two cases quickly about aortic valve repair, and then I go to Ross because I want to emphasize on the Ross today a little bit more. So this is a patient with tri-leaflet aortic valve, as you see, has a central AI, is severe, and that is because of the dilatation of the aortic root. So now I will show you how we measure the geometric height of each leaflet. This is 3D zoom mode of the aortic valve, short axis, and we get it in one bit, not multiple bit. Because if you stitch multiple bit together, but the measurement will not be very accurate. Then we have a 3D, this is the machine that we use it in our center, the EPIC, and we have a software, it's called multi-view. We press that one, and we have this quad screen. So we have a short axis of the valve. This is our index image. We put this cursor line or this axis, red axis, at the middle of the each leaflet and perpendicular to that leaflet. So this way we can measure the geometric height in other view, that's here, and that is the non-coronary cusp. It became 2 centimeters, so it's good. We do the same thing for right coronary cusp. Again, perpendicular and at the middle. It doesn't matter is in systole or diastole. We prefer to measure in diastole, but it doesn't matter because it's a length. So systole, diastole, length of the leaflet is the same. So the right here is 1.89, and the left here we are measuring, it was 1.4. Most of the time, left cusp is smaller than two other cusps. And the left cusp is a little bit in a hidden way in the aortic valve. It's a blind spot for TE. So we might underestimate the left cusp about 2 millimeter in terms of the length. But the rest, we are very accurate. We are doing almost every week in our center. So in this diagram, this is the green one, the one that we measure the geometric height. We try to be at the middle of the cusp and perpendicular. We don't do it in a not at the middle in an edge part or this part. We underestimate it or this way. So by measuring the geometric height, we can calculate the size of the dacron that we should use it for reimplantation. So we take the average of these 3 leaflet height and give 4 or 5 millimeters for coaptation, and we can say how much is the size of the dacron. We measure it for the surgeon. Also, surgeon will measure himself or herself as well. Okay, so this patient had a valve repair and had a valve sparing, and you see the post-op. So this is the dacron here. You see the brightness, and the valve is at the middle. Very good coaptation, and you see almost no AI or very zero AI. The case number 2 is a bicuspid aortic valve. So in bicuspid aortic valve, beside the previous measurement that I showed you, we should measure something else. It's called commissural angle, and I will show you. This is severe type 1. This is severe AI. Already a surgeon start cutting. And this is the commissural angle. So this one is very important. We put the one dot at the middle of this circle and go to this commissure, go to this commissure, and we measure this angle. We have this measurement in the echo machine, in Epic, at least we have it. So if this angle is less than 140, it means this valve is very asymmetric and is difficult to repair. If it's more than 160, it's very good. And so that will, like in this case, it's 156, so it's good. So this is 3 type of the bicuspid aortic valve. Symmetric, angle is 60 to 180. Asymmetric, still is not bad. Very asymmetric is difficult to repair. So this is one of the examples. Beside the commissural angle, we can measure the free margin lengths as well. Also, it's better to measure this 3D. This is 2D picture. And by comparing these 2 lengths, we can say how much pellication surgeon should do it. For example, this larger clasp is 5.5. A smaller one is 4.2. If you want to make the same size, so we have to pellicate about 13 millimeter. That will be like a 3 or 4 stitch of the pellication. So that's a post-op again. See, the valve was preserved and there is no AI. Valve became symmetric now. So it's a true bicuspid and it's very good. What about Ross procedure? The Ross procedure was developed by Mr. Ross in 1967 from in the UK. He's originally from South Africa. He was a classmate of Christian Barnard. It's surprising. In one class, 2 famous surgeons. So what is the rationale behind the Ross operation? The pulmonic valve is the exact copy of the aortic valve in a human being. You see this aortic valve, right cusp a little bit bigger, non-cusp and left cusp. If you put a mirror here, the pulmonic root or valve is exactly mirror image of the aortic valve. Looks like God or nature put another spare valve of aorta in our body. So that's a pulmonic valve. Pulmonic valve, except in congenital heart disease, doesn't have too much disease, will not take rheumatic disease, will not take calcification. So this is a spare valve in our heart that anytime the aortic valve that is more problematic has a problem, we can just switch it. So that's the rationale behind. Again, in this view, this is the aortic valve, this is the pulmonic valve. Again, if you put a mirror here, the pulmonic valve is the mirror image of the aortic valve. So the nomenclature, the pulmonic valve, we call it left, is beside the left of the aorta, right beside the right of the aorta, and instead of none that is posterior, we have anterior. So this one we call it anterior cusp or non-facing cusp. We call it non-facing because it's not facing to the aorta. The 2 cusps are facing here. This animation, how we harvest the pulmonic valve in the Ross patient. So that's actually before surgeon start to harvest the pulmonic valve, we as an echocardiographer, we should tell him the valve is okay or not. Otherwise, he or she will do another surgery, not Ross operation. So this is 3 leaflet. This is very good. Sometimes they have a fenestration. It's not common like aorta, but a small fenestration is okay. What about the guideline? The American guideline says if patient is below age 50 and doesn't want to have a mechanical valve can go for ROS. But this is the guideline of 2020. I'm sure the new guideline will change it. The European guideline, the ROS was not there even in the previous guideline. In the new guideline, they put the ROS as a first option for aortic valve surgery if the patient is young. And then when after ROS, if it cannot be done, mechanical valve and bioprosthetic valve. Again, this is Dr. David, pioneer of the ROS operation in Canada, probably North America. He started to do the ROS operation in 1990, and now we have more than 400 patients that they had a ROS operation, and the analysis of this 400 will be published in 1 month from now. This is a technique, different technique. Dr. David will use inclusion technique, this technique, and what most of our surgeons, the younger surgeon, we have 3 surgeons that they are doing ROS operation in our center. They do this one. So they put a root replacement, external dacron for annulus to not to be dilated, and a short interposition graft here between STJ and the aorta. This is again the paper of Dr. David, which patient is good for ROS. Almost every AS is good, but pure AS is the best, especially if they have a small annulus. But still, we keep this patient for young patients, this surgery. Below age 50 is okay. Now we are doing 50 to 60 as well. Rarely we do above 60. This patient is very good, fit, and has a good LV function. So this is a benefit of the ROS in aortic stenosis. It's very good for aortic regurgitation. There is a chance of dilatation of the autograft, but if you put the dacron outside, we prevent this dilatation. This is Dr. Ismail Al-Hamamsi from Mount Sinai. He was in Montreal, and he is the main person now for ROS operation in the world. He does more than anybody else, and that is his result from Montreal when he was in Montreal. 673 patients. And so he had the perioperative mortality in that time, but now I met him like a couple of months ago in Montreal, and he said the last 150 that he did last year, 0 mortality. This is our result, previous result, but as I said, the new result is coming. This is Dr. Ozonian. She is our head of the division now. This is a result of the Toronto. Most of these cases are done by Dr. David, but now, as I said, Dr. Ozonian is doing and Dr. Chung is doing. So probability of the pulmonary autograft reoperation, 11% in 27 years. And homograph failing in the right side, only 8%. Now we have a very less homograph failing because we have a good preservation, and even autograft failing is much, much less than this. There is any contraindication for ROS? The only contraindication is connective tissue disease, Marfan and Lewis, we don't do it. And if the pulmonic valve has a large fenestration, large means more than 1 centimeter. Otherwise, we can do the ROS. There are some relative contraindication, like a bicuspid valve is not absolute contraindication, is relative. Pulmonic valve, bicuspid is not common like an aortic valve, is like a 1 in 1,000 general population. Autoimmune disease and some other disease. This is the requirement for ROS center. They should do at least 20 ROS per year and more than 50 aortic valve repair per year to be called ROS Center of Excellence. Is surprising that all these 3 authors are Canadian. Hamamsi and Michael Cho from London, and Mark Patterson that was with you before. So case number 3. This is a patient that was booked actually for aortic valve repair. We did this one like 2 weeks ago. Tri-leaflet valve, severe AI. And you see this leaflet that is a left cusp is a little bit retracted. I will show you more. And that retraction is the cause for AI. So in 3D is a gap central, and this leaflet that's the left conic cusp is very small and retracted, doesn't come together. So also this valve was booked for repairs. So algorithm for aortic regurgitation especially, first is a repair, If it's not repairable, Ross is the second option. If Ross we cannot do it, then we go for mechanical valve. So that's a algorithm for aortic regurgitation, especially. This is a pulmonic valve. A little bit PI is okay. And we measure the pulmonic annulus. This measurement is very important in echo. We do it for pulmonary at the end diastole and for aortic at the mid systole. The annulus measurement, they should match together. If it's less than 2 millimeter, is okay. If it's more than 2 millimeter, might need perication. Don't forget the LV function when you do for Ross, because if the patient doesn't have a good LV, forget it. It will not tolerate the Ross. Ross operation is a long pulm run. In the hand of Dr. David is 2 hours and a half, and most of the younger surgeon, this is 3 hours and a half. So it's a very long operation. If the patient has a LV function below 50, we should not do it because patient cannot tolerate. That case, as I said, had a very small left coronary clasp. So we decided that this valve is not repairable and had a Ross operation. And you see very good result, just a trace AI. So this is another case. This is the last case. It's a bicuspid valve. You see it. But the bicuspid was not repairable because there is a fenestration here and the valve had a severe prolapse. So we decided to do a Ross in this patient. This is a bicuspid. Again, it's a little bit dilated. Usually we say if the annulus is above 2.7, is not very ideal for Ross, but still we can do it. Pulmonic valve. And annulus was 32, so they are matching. Only trace PI, pre-op. So the Ross operation was done by Dr. Chang in our center. You see a trace. This is the only operation that you will not give protomin quickly. Just wait a little bit. So, because this is a new valve, it's a pulmonic valve in aortic position. You have to see how this pulmonic valve behave in the aortic position with high pressure. So there is trace, and wait. It became 2 jets, became a big jet. This is in a 20-minute matter because this valve has to adapt in the new place and looks like it is a good leak. So this leak is anterior directed leak, is coming from non-coronary clasp. So we did more picture and we decided that this patient has non-coronary clasp prolapse. So anytime AI is more than mild, and especially is because of the prolapse or commissure, we have to go back. So we made the decision to go back, and our surgeon, Dr. Chang, fixed the prolapse of the non-coronary clasp, and that's a very good result now. So this is a very acceptable. We should not leave the OR for Ross operation with more than mild AI. This is another case. It's not the same case. This is another case that in post-op developed central AI and commissural AI. And again, we went back and we fixed it. So it doesn't, I'm just showing 2 complications. It doesn't mean that every case has this complication. About 3% of the time, we need to go back on POM in Ross patient if it is done by an expert hand. So this is again a paper from Ismail, and he showed that in 675 patients, only 3% of the time, he had to go back and repair the pulmonary autograft in the aortic position. And all of them, they did well after. So in summary, etiology of the aortic regurgitation are mainly dilatation of the STJ or entire root, dilatation, cusp prolapse or cusp retraction, fenestration and calcification. All of this can be diagnosed by echo pre-op. Overall, about 60% of patients with severe AI, they have tri-leaflet. The rest, they have a bicuspid valve. And as I said, the chance of tricuspid leaflet be repaired is above 90% and bicuspid above 70%. But it should be in a dedicated center. TE plays a major role in defining the morphology of the aortic valve, mechanism of the AR, and provides all necessary measurement to help the surgical team for appropriate repair, post-op TE can evaluate the immediate result and predict the repair durability. It's very important. You can have 100% success in the OR, but the valve is leaking next week. That's not good. That's the job of the echocardiographer to say this repair is durable or not. And to say that, you have to always measure the effective height of the valve after repair and coaptation height. If the coaptation height is more than 4 millimeter, effective height is more than 9 millimeter, that valve is durable. Ross procedure has proven to be a durable and effective option for AVR, particularly in carefully selected patients performed by experienced surgeons at high volume center. When we say high volume center, it means center that they are doing more than 20 or 25 Ross per year per surgeon. 25 Ross per year per surgeon. The Ross procedure is the only AVR option with the potential to restore normal life expectancy. The Ross Renaissance, now they call it Renaissance because it came back. The Ross Renaissance refers to a major resurgence in the use of the Ross procedure for AVR. Now in Canada, 5 centers they are doing Ross, and in the whole North America, I think 10 centers they are doing high volume Ross. Many centers they are doing 1 or 2 Ross per year, and they have a very high failure rate. The intraop TE is the only imaging modality available in the OR to assist the surgical team for pre-op selection of the patient and post-op assessment of the result. I just want to emphasize here that especially for Ross, still CT doesn't have a very big role, and we are safe in the OR because CT measurement of pulmonic valve, usually they will overestimate. They overestimate about 5 millimeter. So people, they do, the doctors, they do CT for patient pre-op, but they do mainly for aortic root. For pulmonic root, the only place to measure it and to assess the pulmonic valve is the echo and is the TE. Thank you very much. And I'm ready for take any question.